Hello everyone, this is Colin Quinn. I'm an assistant professor of clinical neurology at the University of Pennsylvania. Dr. Kristen Edmondson, who's also an assistant professor of clinical neurology at the University of Pennsylvania. You will not hear her voice, but she contributed significantly to this talk. First of all, I want to thank Dr. Gupta for asking us to be part of this summit. We're very sorry that we couldn't be there in person, but we're excited to contribute nonetheless. The topic that we're talking about today is myositis mimics. This is a particular topic of interest to me, as I generally focus on genetic myopathies, and it is often the case that adults who are diagnosed with genetic myopathies often were previously diagnosed with a myositis. So the objectives of today's talk, we're going to go broader than just talking about genetic myopathies that might mimic myositis. We want to talk about non-myopathy mimics of myositis. We want to use a kind of framework that kind of through the eyes of a neuromuscular neurologist to get to the diagnosis specifically of myopathy when there might be overlapping features between other neurologic diseases and myositis. We'll reinforce this with case examples, and then we'll also look at myopathy mimics of what we're calling treatable myositis, which will become clear as we talk about it. We'll specifically focus on distinguishing acquired and inherited myopathies and treatment responsive versus non-treatment responsive acquired myopathies. And these will also be supported by case examples. So this is the view, kind of cartoonized view of the peripheral nervous system through the eyes of a neuromuscular neurologist. The circle on the left represents the spinal cord, and the squiggly lines in the middle represent nerve, the little dots represent the neuromuscular junction, and the object on the right represents muscle. This is obviously a lot of territory to cover, and we don't have a lot of time, so fortunately we're going to limit ourselves to pure weakness, and whenever the fellows present to us a patient with weakness, we always try to distinguish whether or not this is pure weakness or weakness with numbness. Because the moment we can say that something has weakness without numbness, when we think we're in the peripheral nervous system, we can cut out a large portion of the localization and really drill down to these three sites, either a problem of the muscle, the neuromuscular junction, or the anterior horn cell or motor neuron. And focusing on these three topics, each has kind of distinguishing characteristics that I'm sure you're aware of, but it is helpful to think about, and helpful for us when we have a patient in front of us to think of, could we be fooled by overlapping characteristics between these three separate regions of the peripheral nervous system. So to review quickly, anterior horn cell or motor neuron disease, also known as ALS in the United States, typically presents with a non-fluctuating progressive weakness. There's atrophy, fasciculations, cramping. Sometimes patients have pseudobulbar affect when they laugh or cry inappropriately, and that can be helpful in distinguishing motor neuron disease from other entities. They often have dysphagia or dyspnea, which can be seen in almost any of these three localizations. On further investigation, they can often have a modest CK elevation. We usually use a rule of 1,000 that's occasionally broken, but if we see a CK of greater than 1,000, we tend to be a little suspicious that there might be something other than motor neuron disease going on. And at the same time, a CK of 800 is well within the bounds of reason for motor neuron disease. And the EMG is often quite helpful, as we can see active denervation in the muscle on the needle study, and signs of chronic reinnervation in which motor units that are remaining are much larger because they're being supplied by fewer neurons. The neuromuscular junction causes a characteristic pattern, typically of fluctuating weakness, although this may be less true in presynaptic disease. Ptosis and diplopia are often a feature of myasthenia gravis, a postsynaptic neuromuscular junction disorder. Associated cancer, particularly in older men with neuromuscular junction disorders, should be considered. and dysphagia and dyspnea are often features. We do not expect CK elevations in neuromuscular junction disorders. We do expect that RepStim and single fiber testing to be positive, although this is not always the case. In severe cases, which can be confusing, the EMG may appear myopathic in a neuromuscular junction disorder, and in generalized cases, we do expect positive antibodies of some form, although again, this is not 100% sensitive. Muscle disease is typically a static, proximal, or distal weakness. Both patterns can be seen. It's usually progressive over time, with the exception of maybe the congenital myopathies, in which the history is usually fairly clear that there was very early onset weakness that's been quite stable. Ptosis, dysphagia, and dyspnea can be present in various muscle diseases, but is often not a prominent feature in most myositis, maybe with the exception of dysphagia, which can be seen in, for example, polymyositis. The CK is usually elevated, and that's something that we look for in acquired myopathies, maybe with the exception of dermatomyositis. And on EMG, we expect small motor units with early recruitment on the needle study. We're a little cautious when we hear a chronic myopathy story, as they can look a little bit more what we call neurogenic with large motor units. So these are the three categories that we're going to try to take the first couple cases through to see if we can sort myositis from non-myositis. So we first want to look at this through the lens of non-myopathy myositis mimics. So we'll start with a case. So the first case is a 53-year-old woman with proximal muscle weakness, dysphagia, and dyspnea. She was referred by her primary care doctor after reporting to her that she developed progressive proximal arm weakness over the previous 4 to 6 months. There also seemed to be some leg weakness as she reported difficulty going upstairs. She reported some dysphagia and shortness of breath with exertion. Her primary care doctor checked a CK, which was 743, so she was actually referred to neurology for a possible myositis. Looking at our categories, you can see that there's some overlap between motor neuron disease and the muscle categories, in that they both have progressive weakness that's non-fluctuating. The patients may have dysphagia in either case, particularly say for polymyositis or inclusion body myositis. And again, this is a good example of where a modest CK elevation can cause confusion, as people don't usually attribute CK elevations with neurogenic disease, but usually at less than 1,000, we don't think that motor neuron disease has been excluded at all. So that was the referral on actual neurologic evaluation in our clinic. We got some further history that's quite helpful. She had developed muscle cramps and muscle twitching, and on exam we could see these fasciculations in the arms and legs. She had fairly diffuse weakness both proximally and distally. She had some hyperreflexia in the arms. A repeat CK was elevated, but again, this can be seen in either motor neuron or myopathic disease. Her EMG is quite helpful in that there was active on chronic deinnervation and reinnervation diffusely, consistent with an active on chronic neurogenic process. So bringing it back to the categories, it seems this is most consistent with motor neuron disease. And I think what threw off the primary care doctor was the presence of CK elevation, but again, that can be seen in motor neuron disease. The EMG is quite helpful, and really clinically, the presence of fasciculations indicate a nerve problem. So that muscle twitching comes from the nerve itself, and really, so only motor neuron disease can, only nerve processes can cause those fasciculations. So this patient had amyotrophic lateral sclerosis, and over the subsequent months, her weakness rapidly progressed, and she is currently on home hospice. Our second non-myopathy, non-myositis case is a 71-year-old woman with proximal weakness, dyspnea, dysphagia, ptosis, and diplopia. She has a rheumatologic history and had been followed by a rheumatologist. She had 4 months of muscle aching in her arms and legs prior to being evaluated in our clinic. She then developed proximal arm and leg weakness, which worsened as the day went on. She had 2 months of difficulty swallowing and some problems generating volume of her speech, and her dysphagia had progressed to the point where she was not taking in enough food and had lost quite a bit of weight. At the time of our seeing her, she had 2 weeks of left eye ptosis and some blurring and double vision. She saw her regular rheumatologist who checked her CK that was normal, but I think out of concern for her history of rheumatologic illness, there was concern for myositis. Her rheumatologist started her on 20 milligrams of prednisone that she couldn't actually swallow, and she came to neurology for further evaluation. So looking at this patient through the lens of our localization outline here, she appears to have fluctuating weakness along with ptosis, and she has dysphagia, which can be seen in any of these motor neuron, neuromuscular junction, or muscle processes. She does not, however, have a CK elevation, which again should raise suspicion that there is not an acquired or subacute myopathic process going on. However, this does not exclude the possibility of motor neuron disease. On neurological examination, she was noted to have bilateral ptosis, worse on the left, with curtaining, which is where you pull one eyelid up and the opposite eyelid sags down. Her ptosis was fatigable in that when you asked her to look up, her ptosis would get worse. She had impaired extraocular eye movements. She had dysarthria, and repeat manual muscle testing demonstrated fatigue. Her single breath count was 7, which is how high she can count in a single breath, and that is quite low. She was admitted to the ICU for further evaluation, where an EMG actually showed a myopathic pattern. Her acetylcholine receptor antibodies, however, were positive. We did a CT of the chest, and it was negative for thymoma. So in this case, this patient has several features that could be concerning for a possible myositis. She has this rheumatologic history. She had a predominantly proximal weakness pattern, but most of the evidence points to her having a neuromuscular junction disorder. She has more fluctuating weakness. She has ptosis, which fluctuates. Again, that's a critical feature that you can make her ptosis worse on exam. And then there are several features of the investigations that would support a neuromuscular junction disorder. In this case, the diagnosis is myasthenia gravis. She did quite well with treatment, with the exception of some persistent proximal weakness, which is not that uncommon. So next we want to focus on a patient who we believe has myopathy, but we want to be sure that it's not a mimic of a treatable myositis. This is somewhat biased from my own practice, but the first thing I'd like to do when I believe a patient has a myopathy is take a step back and be fairly confident that they have an acquired myopathy rather than an inherited myopathy. And of course, the key here is often the history. And what makes it hard is that patients often report that something just happened, and it's often set off by a certain event. For example, they fell and they come to the emergency department, they're found to have a high CK, and the story is that this all happened around the time of the fall, and it's a little bit of the cart leading the horse. Then if we asked further questions, we would find that this is actually a more chronic problem and that they've been very slow to adapt. And when you adapt slowly, you often don't recognize the changes in your body. The weakness pattern of an acquired myopathy is typically proximal with the exception of inclusion body myositis, which we'll talk about separately, whereas an inherited myopathy may have either proximal or distal patterns. Obviously, the distal patterns don't tend to get confused for myositis frequently. Another relevant piece is asking medical history, which might help point to a diagnosis. If a patient has a history of a connective tissue disorder, obviously that raises our suspicion for a myositis. It shouldn't be the beginning and end of asking a history, but it is important. Dermatologic changes, which I'm sure are better identified by other speakers, including Dr. Worth and people in the audience than myself, but I'm good enough to recognize when someone has clear dermatomyositis changes. A history of pulmonary fibrosis, which can accompany the myositis, or recent cancer suggesting a paraneoplastic myositis. And toxic exposure should be discussed with all patients who present with a new myopathy.
So if we believe that we have an acquired myopathy, what we like to think about is distinguishing the treatment-responsive acquired myopathies, also known as inflammatory myopathies, including dermato-, poly-, and necrotizing myopathy, from non-treatment responsive acquired myopathies, so, with the biggest example being inclusion body myopathy. In the treatment-responsive myopathies, there's usually a subacute onset, relatively rapid progression over weeks or months. The pattern of weakness is usually proximal. On investigation, you almost always find a CK elevation, with the exception being maybe dermatomyositis, in which there's predominant skin disease. But if I don't see a CK elevation, I'm often suspicious that we're not on the right track. I'm not going to get into the laboratory assessments here. The EMG is typically myopathic. However, we have seen patients where we're fairly convinced they have an inflammatory myopathy, and we didn't see much on EMG.
So we define inflammatory myopathies between treatment responsive and treatment unresponsive. What we're really talking about are dermato-, poly-, and necrotizing myopathy as the treatment responsive, and inclusion body myopathy as not treatment responsive. And hopefully one day that won't be the case, but for the time being, that's how we divide them. In dermato-, poly-, and necrotizing myopathy, there's usually a subacute onset with fairly rapid progression. The weakness pattern is usually proximal. In dermatomyositis, obviously you expect certain skin changes. We expect a CK elevation in almost all of these patients, maybe with dermatomyositis as an exception. If the CK is not elevated, I am typically at least suspicious at first that an inflammatory myopathy is the cause of a patient's weakness. I'm not going to review all of the labs. We send, I think that the audience probably knows the myositis specific antibodies as well as, if not better than I do. We tend to send HMG, CoA, and SRP antibodies in patients with necrotizing myopathies seen on biopsy. The EMG would expect it to be myopathic, obviously.
And of course, in these patients, we expect usually to get a biopsy. I don't really want to review the specific biopsy features here, but suffice it to say there are specific biopsy features of each of these diagnoses. What I did want to spend some time on was in a treatment unresponsive acquired myopathy, inclusion body myositis. We see a fair amount of inclusion body myositis in our practice, and it's not that uncommon that a patient will present having been treated for polymyositis, and in reviewing their clinical history and studies, the diagnosis of IBM is clear. So we expect a slower progression usually in this disease, although I do have patients who have more aggressive forms of IBM. Commonly, patients have difficulty with stairs and opening jars, I had mentioned previously. They often have a dysphagia that's more esophageal in character, meaning that food gets hung up down in their throat, and less of the dysphagia that you might expect, say, in ALS, in which it's often pharyngeal in character, in which they feel like their food is kind of going down the wrong way and they're coughing quite a bit while eating. We do not try to treat inclusion body myositis, but often they have been treated and are generally unresponsive to immune therapies. CK elevations are variable and can be not seen in IBM. We expect a myopathic pattern, although sometimes IBM is so chronic that it can lose its kind of classic myopathic pattern on needle EMG. We do send NT5C1A antibodies, which is a specific but not sensitive marker seen in 50 to 70% of patients with IBM. Now, if we have a classic story of a patient with quadriceps and finger flexor weakness, slow progression, and a positive NT5C1A antibody, it may be questionable as to whether or not we do the biopsy. However, we often do biopsy these patients and see the rimmed vacuoles that you can see in the muscle fiber all the way to the left and then all the way to the right here. And then there are often signs of mitochondrial failure, so it's common to see ragged red fibers. And changes on Cox SDH stains in which you've had dropout of the Cox staining with residual SDH staining as seen in the blue fibers here. We actually don't see as many inclusion bodies despite the name, although that is a feature in which you can see accumulations within the cell. The important message from inclusion body myositis, as far as I'm concerned, is that it does not appear to respond to immune therapy, and that's why we're spending some time on distinguishing it from a treatment-responsive acquired myositis.
So now we'll spend some time on additional cases in which we believe that a patient has myopathy, but we're trying to distinguish whether or not this is an acquired myopathy versus an inherited myopathy, or an acquired myopathy that would be responsive to immune modulation. So the first case is a 53-year-old woman with a history of rheumatoid arthritis and severe subacute weakness. This is actually a very interesting case seen by a colleague of mine, so I'll admit I didn't see this patient, but I thought it was a good example of what we're after. So she had severe rheumatoid arthritis diagnosed 10 years ago. She underwent multiple treatments. She stopped all of her medicines approximately 5 years ago. And then her RA unfortunately continued to progress. She saw rheumatology the year prior to seeing us, had multiple rheumatologic markers that were fluoridly positive. She was started on Plaquenil and methotrexate. She came to the hospital after spending 2 weeks at an outside hospital with hypercarbic respiratory failure. She had initially presented to the outside hospital with progressive lethargy and cognitive changes likely due to her respiratory failure. She did have mobility issues, but that had appeared to have declined in the months leading up to this episode of respiratory failure. So on exam, she had fairly severe diffuse weakness. She was on invasive ventilation, so she was communicating using her writing board. Her CPK was actually quite low. Sometimes when someone's this weak, I do worry about that there's been so much muscle loss that there isn't a CPK to kind of give up. Her EMG was consistent with a myopathy. She had negative neuromuscular junction antibodies. She had a muscle biopsy of the quadriceps that revealed severe myopathic changes, but concerning, she had numerous vacuoles, which suggested that this may be a toxic exposure. So this patient distinctly does have muscle disease. She clearly has progressive weakness. She doesn't have substantial elevations in her CK, so that could throw you off. But her EMG supports a myopathic process, and her biopsy also is consistent with a myopathic process. However, given her history, you might think, okay, that this is probably a myositis related to her history of rheumatologic disease. The concerning factor for us was actually that the CK wasn't elevated and that she was so severely weak, and there were these vacuoles kind of diffusely in her biopsy. She was diagnosed with a toxic myopathy from Plaquenil, which can produce the biopsy features seen here, and she was taken off Plaquenil and steadily improved. Obviously, when reviewing toxic exposures, the biggest player is usually the statins. They can cause both a toxic myopathy and a necrotizing myopathy requiring immune modulation. I think that, speaking of immune modulation, steroids are often. So our next case is a 74-year-old man with progressive weakness and dysphagia. He was previously diagnosed with polymyositis. He reports that 5 years ago he had difficulty getting up from a chair. He had approximately 3 years ago developed esophageal dysphagia and been diagnosed with a Zenker's diverticulum. He his CKs have been in the 300s to 900s as he'd been followed by rheumatology. His EMG was myopathic, but his muscle biopsy was thought to be consistent with myositis. This muscle biopsy is his actual sample, and as you can see, he has lots of inflammatory cells surrounding multiple cells, and some cells that are actually actively being phagocytosed. Initially, his statin was thought to be a possible cause, and this was discontinued, but that didn't improve. Then he was started on prednisone for polymyositis, and he did not improve. So again, clear myopathy, he kind of checks all the boxes, but the question is, does he have a myositis which should respond to treatment? So was sent to neurology for a second opinion. The history that had been obtained was accurate. Additional history was that he had difficulty opening bottles, and he had noticed progression of his dysphagia over time. He denied any family history. He had clear atrophy and weakness that was somewhat diffuse, but worst in the flexor compartment of the forearms, the anterior thighs, and the ankle dorsiflexors. NT5C1A antibodies were sent and were positive. So the diagnosis was inclusion body myositis. We discontinued immunomodulation. So our last case is actually a very recent case that I saw just last month. This is a 19-year-old woman with hyper-CKemia and proximal muscle weakness. And recently, in June of 2018, she experienced fatigue. While she was working quite hard, she was holding multiple jobs, and she started to get quite tired. She went to an outside hospital basically because of this fatigue, and her CK was found to be 7,000. This was rechecked, and her CK was still quite elevated at 3,000. She was seen by a neurologist who noted proximal greater than lower extremity greater than upper extremity weakness. She had a muscle biopsy performed of the right thigh, which was thought to be potentially a immune-mediated necrotizing myopathy with evidence of atrophic fibers. She was treated with high-dose steroids for 6 weeks with significant improvement of the CK, but she was still weak. There was no change in her strength. And they were proposing starting IVIG therapy. She came to our office for a second opinion. So again, this patient pretty clearly has a myopathic process. She has CKs that are way too high to be anything but a myopathy. She has proximal weakness in a pattern that would be consistent with a myopathy. So when I saw her for a second opinion, I think the most notable issue was that she said she felt fine. She didn't notice that she was weak at all, and this to me is a red flag for an acquired myopathy. She reports that she swam long distance in high school, so she kind of dismissed the idea that she could have been weak, but actually when you drilled down on this, she could only do long distances and noticed that she could never really get faster. She had pretty clear proximal weakness despite her lack of awareness, and she had large calves on exam. So her high CK, and then I would say combined with her lack of awareness of weakness, made me very suspicious that she did not have an acquired myopathy, and in fact that she had inherited myopathy. I feel like this can be a fine point, but patients really should be aware of weakness if the onset is subacute. But a patient who has very, very slowly progressive weakness can just slowly adapt and may not notice a thing. I've had multiple patients report that they're here to see me for hyper-CK-emia and that they have no weakness, and then I watch them walk and they have a clear waddling gait or they can barely reach overhead. So in this case, I sent a comprehensive neuromuscular disorder panel, which revealed homozygous mutation in FKRP, which is a common Northern European, common cause of myopathy in Northern Europeans. And this fit her pattern pretty exactly. It tends to have a high CK, they can have enlarged calves and proximal weakness. So in the United States, we've really shifted. I'm not sure what the practice pattern is in India, and I apologize if this doesn't apply, but here, we used to do this kind of hunt and peck method of genetic testing in which we would have a sense of what we thought the patient might have and send maybe a single gene for Sanger sequencing. It was expensive, and you didn't get any discount for ordering multiple genes. Now we tend to send these next generation panels in which they cover all of the genes of interest, provided they're not repeat disorders. The other thing you have to be aware of is whether or not deletion and duplication testing is being done, because you'll miss large deletions or duplications on just standard next generation sequencing. We have inverted things in that we used to do biopsies for basically all patients with muscle disease, but now we often skip the biopsy and go straight to genetic testing, and then if there's no results or there's a variant of undetermined significance, we perform a biopsy. And obviously, if we're unsure whether or not something is acquired versus inherited, we often find the biopsy helpful. So that completes this talk. Thank you very much for the opportunity to speak with you all today. I'm sure Dr. Gupta will let me know if there are any questions, and I hope you all have a great conference. Thanks again.